Okay, welcome everybody to this next Young Science Iran Petchem webinar, and it is my great pleasure today to be the moderator of this webinar. And our presenter will be Malgorzata Styczewska. She's from Poland and will present a very challenging case of an EBV-positive gastric carcinoma. And it is also my pleasure that Professor Dominik Schneider will be the expert today. Hi, Dominik.
Hi.
He's a very well-known expert in germ cell tumors, but also especially in rare pediatric tumors. He is working in Dortmund, and he's also involved, of course, in the European project, which is called Expert, dealing with rare pediatric tumors. So I will stop talking now and ask you, Malgorzata, to present your case, and Dominik will then be involved in the discussion with you about the case, and I will try to collect cases. So please put your questions and comments into the F&A, and I will try to bring the questions to Dominik and Malgorzata. So the floor is yours, Malgorzata.
Okay, I will try to share my screen. Is the presentation visible?
Yes.
Okay, so thank you for this opportunity. My name is Malgorzata Styczewska. I'm a pediatrics resident in Gdańsk in Poland, and I would like to present a case of a teenage patient with EBV-positive gastric carcinoma to discuss therapeutic challenges in this rare case. We have no conflict of interest. The patient was a 17-year-old male who presented with significant weight loss, dyspeptic symptoms and fatigue, and initial laboratory investigations revealed profound iron deficiency anemia. The patient underwent upper gastrointestinal endoscopy in outpatient setting, which revealed gastritis and duodenitis. The biopsies were performed and Helicobacter pylori infection was found. The patient received symptomatic treatment with red blood cells transfusion, eradication of Helicobacter, and iron supplementation, which led to transient improvement. However, unexpectedly, the initial biopsy result came with suspicion of malignancy. And here we go to the first question. What is the most common gastric solid tumor in children and adolescents? Adenocarcinoma, gastrointestinal stromal tumor, neuroendocrine tumor, leiomyoma, or inflammatory myofibroblastic tumor.
And just as a comment, you either saw the question pop up on your screen or you can answer in the chat.
I'm having a look, Martin, on the percentages, but I don't see any answers so far.
Maybe people are shy. So look in the chat and you can select. Yeah, Malgorzata, you can continue, but you can select the answers.
Okay, I will continue. So the right answer is GIST. However, all of these entities are in fact rare. In our patient, the biopsy material obtained from the gastroduodenal junction revealed adenocarcinoma. The HER2 immunohistochemistry was borderline, and the Ki67 was 40 to 50%. And at this point, the patient was referred to our pediatric oncology department. At admission, he presented in fairly good general condition. He reported improvement after antibiotic treatment. And also he reported a history of nausea, vomiting episodes occurring every few days. At the day of admission, we performed a CT scan, which revealed a pathological thickening mainly of the duodenal wall with involvement of the head of pancreas. Additionally, numerous enlarged lymph nodes were visualized, mainly in the hepatic hilum, in the mesentery and ileocecal region. There was no evident peritoneal spread or distant metastasis, except non-regional lymph nodes. And as the family and the patient denied the initial rare diagnosis, we decided to repeat upper GI endoscopy with multiple biopsies. And the histopathology, both the morphology and the immunohistochemistry, confirmed diagnosis of adenocarcinoma, probably deriving from the gastric tissue. However, there were also some new insights. The tumor was described to have so-called lymphoid stroma and the EBER immunohistopositivity, which altogether supported the diagnosis of EBV-dependent gastric carcinoma. The patient was at this point consulted in the multidisciplinary tumor board with adult oncologists and with oncological surgeon, and the tumor was deemed inoperable, especially that the lymph nodes involved were not regional, so the patient was qualified to have metastatic disease. In our biopsy, there was no HER2 expression, so the patient had no indication for HER2 inhibitors. And because of his young age, he was excluded from the clinical trials available for patients with gastric carcinoma in our institution. Therefore, we decided to start the treatment according to ESMO guidelines for adults. And the biopsy material was sent for molecular examinations. The patient started chemotherapy. However, after the first cycle, we observed rapid progression of the disease. So it was decided after another discussion with adult oncologists to change the treatment for another scheme, which led to short stabilization. And at this point, we received the extended molecular and immunohistochemistry examinations, which revealed PD-L1 expression in 20% of the cells, typical BRAF V600E pathogenic variant, and two pathogenic variants in PIK3CA. The patient also underwent germline testing, which was negative for pathogenic variants predisposing to cancer. And here is another question. Which of the following cancer predisposition syndromes is not associated with increased risk of gastric carcinoma? Is it Peutz-Jeghers syndrome, Lynch syndrome, FAP, hereditary diffuse gastric cancer, or von Hippel-Lindau disease?
Some responses are coming in. I will just inform you. Let's wait perhaps another minute or half minute.
Okay.
So far, people say answer number 5.
Yeah. Should we move on or wait a bit longer?
I think you can move on.
Okay, so the people were right. This is the only syndrome from these 5 which is not associated with substantially increased risk of gastric carcinoma. And all of the findings together, apart from this BRAF pathogenic variant, which is in general rare in gastric carcinoma, indicated that the tumor may be a so-called EBV-dependent gastric carcinoma subtype according to the Cancer Genome Atlas Research Network. This is a rare type of gastric carcinoma. It makes up to 10% of all gastric cancer patients, and it is described in the literature that it may be responsive to immunotherapy treatment. And therefore, we decided to add pembrolizumab to the FOLFIRI chemotherapy that the patient was receiving. However, unexpectedly, we encountered massive progression after starting pembrolizumab. And in the literature, both so-called pseudo-progression after immunotherapy and hyperprogression phenomena are described, and the interpretation of the response might be very difficult at the beginning. However, in our patient, the progression was so dynamic that the boy required many local interventions. He underwent 3 times stenting of the duodenum, and here on the right, you can see even dislocated stent that required surgical removal. He also had cholestasis and required hepaticogastrostomy. And because of the cachexia, he required many nutritional interventions, and both parenteral and enteral nutrition was started. Therefore, we decided to switch him to targeted therapy with dabrafenib and trametinib. This treatment was complicated with typical side effects for this combination, which improved after systemic glucocorticoids. And on this treatment, the patient achieved partial response for 5 months with really good quality of life and outpatient treatment. And another question, what is false regarding the combination therapy with BRAF and MEK inhibitors? First, majority of patients have cutaneous toxicities. Second, the combination treatment with BRAF and MEK inhibitors is associated with a higher overall toxicity burden than monotherapy with BRAF inhibitors. 3, the patients require regular cardiological and ophthalmological assessments. 4, fast tumor regrowth may be observed after cessation of the treatment. And 5, all are true.
I think with this question, we give the people a little bit more of time.
Okay. Do we have any answers?
I'm just looking. We have a few. So we have one saying number 5, one number 4. Yes, you have 2 replies. One saying number 4 is false, also the right answer, and one is saying number 5 is the right answer.
Okay. So, should I move on?
Yes, of course.
So this is the right answer. The combination false answer. That the combination treatment is associated with higher overall toxicity, because the combination treatment has different spectrum of toxicities than BRAF inhibitor monotherapy, but in general, less skin toxicities are observed when the combination treatment is used. There is less paradoxical activation of the MAPK pathway. And the other sentences are true, the first, the third, and the fourth. Our patient, unfortunately. Sorry. I could hear some problems with my microphone.
No, everything's okay with your.
Okay. So in our patient, unfortunately, after this 5 months of partial response, another massive progression with worsening abdominal symptoms was detected, and we tried to enroll the patient to clinical trial with PIK3CA inhibitors. However, due to worsening general condition, he did not fulfill the inclusion criteria, and we referred him for the best supportive care at home. And the patient died due to progressive disease with overall survival of 15 months. And now I would like to ask for the discussion.
Okay, thanks a lot. I'm looking into the chat to see. Well, but perhaps Dominik, you would like to.
Thank you very much. This excellent presentation of a very difficult case, which really also leads us into the depth of the molecular targeted therapies. And maybe I may comment that in the German group, we have done an analysis of 13 gastric cancers in children and adolescents. 3 years ago, the work was, or 2 years ago, the work was guided by Michael Able from our group. And in this small group, I mean, it's still one of the largest pediatric cohorts, but in this small group, we have seen no EBV-positive or EBV-associated gastric carcinoma. So even if gastric carcinoma is rare in the pediatric cohort, your patients is super, super, super rare. And so this is really a very unique case, and it's really great that you're presenting the case here, and maybe it's worth considering a case presentation in a journal, because this is so unique. Regarding the therapy, I think you did an excellent job, and you used all the chances that you can use in this, or options that you can use in these cases. And I said this is a infection-driven tumor, so the idea is really to combine a kind of chemotherapy with checkpoint inhibitors, and this is really a smart strategy. And otherwise, I think it's just if you have a tumor stage that's so far progressed, it's that you have very limited chances to get these tumors under control. So you really did a great job, but this was a very unfortunate tumor patient.
Thanks a lot, Dominik. May I ask you, Malgorzata, one question, but perhaps I missed it and you said it. How did you differentiate between pseudo-progression under the checkpoint inhibitor and progression of the disease? Perhaps I missed it in your presentation.
To be honest, it was just such a dynamic progression that its reason was not that important to us at this point, because the patient required many of local interventions due to progressive disease, and we couldn't wait anymore, because even if it was pseudo-progression, the patient had worsening symptoms, so we had to change the treatment. And also probably if it would be only pseudo-progression, the patient wouldn't be deteriorating clinically so much. So to us, it was more likely to be a true progression, and that's why we changed the line of treatment quite early.
Okay. Thank you. I'm looking into the chat. We have a few people here, but I will see if there's a question. So far, not.
So this has been so mind-blowing. I mean, maybe I can point to one thing. As you mentioned, that we're working in the European Cooperative Study Group on Pediatric Rare Tumors Expert. And for these really unique cases, we have an option to discuss these patients at the European platform. You may know the CPMS, Clinical Patient Management System platform, and then you can present these cases in a protected chat environment, and this is very easy to use. And I know that the start of this project is a little bit lame, so the discussions sometimes take a time to get on rolling, but we should use this tool more often to get this thing running and to really exchange on these exchange experience and exchange thoughts on these really unique patients.
Yeah, I could completely agree. We should really use this platform. Perhaps Martin, you could also comment very briefly where we are with the new version. Martin, would you comment?
Yes, thank you, Andishe. Yeah, we have the version 2.0 live since February last year, and I would recommend everybody go to the ERM PETCAN website. We have a dedicated section for the CPMS, where we also describe the groups that we have set up. For example, one group led by Dominik Schneider for the very rare tumors from the expert group, and he's showing it to the camera.
You can use it
There's
on
also you can also use it on your phone. There's a mobile app where you can do all the discussions and even join video meetings that are being held on this platform. And it's a great tool to discuss in cross-border settings, very difficult cases that you might encounter in your clinical daily practice.
And I think especially for the case, Malgorzata, you presented, this would be, or for such cases, this is the ideal way to go, because here I think we can only learn from the expertise that is collected by the expert group, for example, because such a case is so rare that you really should have an exchange with people who might have seen perhaps some more cases. Yeah, I think I will look once more into the chat if there is a question left, but I don't see any questions. So Malgorzata, would you like to conclude somehow your case, and what was the main learning point for you? What was the take-home message? Oh, sorry, there's the slide.
I have
Great.
some. So pediatric gastric carcinoma has distinct clinical, histologic, and probably molecular characteristics. And there's possible role of Helicobacter pylori infection and concomitant genetic predisposition of or immunodeficiency. These take-home messages are also based on some literature review. And patients with gastric carcinoma who are children and adolescents have unfavorable prognosis, which is similar to adult patients, and long-term survivals are only observed after complete tumor resection. Precise clinical and biological characterization of a larger group of patients is necessary to develop therapeutic guidelines adapted to the distinct biology of tumors in this age group. And what's already been said, in difficult cases of rare tumors in children, international consultation should be considered.
Okay, thanks. I think these messages are very clear. And Dominik, would you like to add anything?
I mean, I think to make it very short, it's networking or not working. If you have these rare cases, find friends and discuss patients together. I think that's the most important thing. Otherwise, you are seeing one patient and you see the second patient in another life.
Yeah, I agree. And I think this is even true for the very big centers. Even big centers may only see once in a lifetime such a case, and all the big centers should really contact boards or cooperative projects like the expert group to discuss these cases. This is not only a topic for small centers, but also for the big centers.
Exactly. Yeah.
Okay, then I would close this webinar. Thanks for being in time, Malgorzata. Thanks, Dominik, for joining us. I know you're busy, but it was great that you took part and commented the case. Thanks for the people who have joined this webinar today. And Martin, the next webinar will be in April or in May. I don't know.
The next one is in May. The next one is in May. And you can find all the ones for this year on the PetCan website.
Yeah. Which case we are going to discuss next time? You know it?
I know that Gianni Bisogno will be the invited expert, and another colleague from Giulia Fiumana. She will discuss the case alveolar rhabdomyosarcoma with diffuse bone marrow involvement.
Okay.
Yep.
Yeah, it's a case of the leukemic presentation, I remember. Yeah.
Yes.
Good. Thanks a lot. Then I wish all a nice evening, and thanks for being around today. Ciao, ciao.
Okay, ciao.
Thank you.
Thanks a lot.
Thanks, Malgorzata.
Thank you.